Hello, good morning students. I hope you are in the house taking adequate precautions like hand washing for corona and wearing a mask. Today we will be talking about renal and ureteric trauma, having finished the congenital abnormalities. This is an important trauma and polytrauma. When there is a road traffic accident or blunt abdominal injury, you have to think about renal and ureteric trauma. So let us recapitulate certain topic about the anatomy of the kidney, which is very important in the management. Kidneys are situated in the retroperitoneum. Remember that kidneys are in the retroperitoneum, and you have already been taught how to diagnose a kidney mass by means of its location, bilaterality, bimanual palpability, not falling forwards and knee elbow position, things like that. All are signs of retroperitoneal masses. Are normal kidneys normally palpable? Usually not, but in very thin individual, they may be palpable on deep inspiration. So they are situated in the retroperitoneum. Length is about 3 vertebral body lengths, and the kidney is intimately related to the vertebral bodies and transverse processes. So you have to remember this. This is an important anatomical thing, wherein you have to suspect a kidney trauma if there is trauma to the vertebral bodies, L3, 4, and transverse process, fracture or transverse processes. So kidney lies along the borders of psoas muscles and also obliquely placed about 30 degrees, which you have come to know last time about the anatomy and rotation of the kidneys. An important thing about the kidney is kidney has a capsule which is closely applied to the kidney. Then it has got the perirenal fat, over which there is a thick fascia called xerotas fascia. So all these things give a protection to the kidney, which prevents the bleeding from going out of the renal trauma. So also kidney is protected by its renal vascular pedicle, which fixes the kidney. It doesn't move freely. The abdominal muscles, thick abdominal muscles and post-abdominal wall musculature also protects the kidneys from trauma. So these are all the protective things by which kidney usually escapes trauma and also protected. And each kidney is capped by an adrenal gland, and both organs are enclosed in xerotas fascia separately. As I said, kidney has itself 3 layers: capsule, perirenal fat, and xerotas fascia. This xerotas fascia is very important because it protects the kidney and it limits the bleeding from coming out. This causes an effect called page kidney, wherein there is increased tension within the xerotas fascia, which may lead to hypertension, which is a hyperrenemic hypertension. And also, this controls the bleeding because of the pressure tamponade effect over the kidney. This limits the bleeding also. So this xerotas fascia is very important to limit the bleeding, to control the bleeding. And you have to remember the page kidney effect while treating this, because it produces hypertension. And you also have to remember that while doing operation, if there is no, you do explore for something, there is a retroperitoneal hematoma contained in the xerotas fascia, you are not supposed to cut it because the tamponade effect will be lost and there will be torrential bleeding. Such is the importance. Retroperitoneal hematomas are not cut unless there is pulsating hematoma or increased bleeding. They are not disturbed, incidental retroperitoneal hematomas, because the tamponade effect of the xerotas fascia will be lost and there will be bleeding. Renal arteries, again you have to remember, they can be single or multiple renal arteries, because when you are planning for surgery on the kidney, you have to know these, keep it in mind that there could be multiple renal arteries. Renal vein, right renal vein directly empties into inferior vena cava. This is another thing you have to remember about the kidney anatomy. As you know, yes, as you see in the picture, this is where the kidneys are located. The right kidney lateral to the vertebral column, high on the body wall, under floating ribs. So these ribs are also important. If there is a fracture of the ribs, floating ribs, 11 and 12, you have to remember that there could be an injury to kidney in those cases. One is fracture of the transverse fossa of the spine. This is ribs. These things you have to keep in mind. And retroperitoneal position, and the right kidney is slightly at a lower level than left kidney because it's inferior to left kidney in order to accommodate the liver. Liver is there on the right side. So left kidney is at a higher level than right kidney. You have to remember this. It is surrounded by a renal capsule with a fat pad. And you see here, the kidney's location here, and the blood supply comes from the aorta, arterial supply, venous drainage into vena cava. And it has got an outer layer, kidney has got an outer layer cortex, inner medulla, and the pelvic calcium system. Why this is important in treating kidney trauma also. It's a minor injury to cortex, can be managed surgically, conservatively. If it communicates to the renal pelvic system, there will be big hematuria and you have to treat that. And this is expanded proximal, it's called renal pelvis. So this is important part of the renal anatomy, which you have to remember while treating renal injuries. Renal injuries are very common. Blunt abdominal trauma or penetrating trauma. These are two types of injuries to the kidney. Blunt abdominal injury or penetrating injuries. Blunt abdominal injuries are caused by road traffic accidents or boxing injuries. Whenever there is a boxing championship in the town, we used to get more number of boxing injuries because of a direct hit in the loin, which injures the kidney. There will be hematuria, but most of them are treated conservatively only. If there is hematuria after a trivial injury, suspect that there could be a pre-existing disease like tumor or hydronephrosis or something. A closed renal injury is almost always retroperitoneal, doesn't communicate to the peritoneal cavity. Except in very young children, there is less of perirenal fat and all these coverings of the kidney, and they are very much prone for injuries. That's why young children, you have to think of probability of renal injury. High suspicion should be there because classical manifestation may not be there. If the peritoneum is torn, blood and urine are contained in the peritoneal cavity, which are obvious signs of free fluid in the peritoneal cavity. Blunt trauma directly to the abdomen, flank, or back, as I said in the boxing injuries, account for 80 to 85% of the injuries to kidney. Fights, falls, and contact sports, as I said, boxing is a contact sport, and other sports, contact sports, the chance of injury to liver, kidneys are more. And vehicle collisions, another important reason for kidney injury, there can be two ways. One is due to acceleration and direct impact. Two is a deceleration injury. When there is sudden deceleration, there could be a major vascular injury to the kidney. This is a deceleration injury, very typical, and you have to suspect that. Gunshot and knife wounds cause most penetrating injuries in the kidney, and the thing is, everything has to be explored because of risk of injuries to other viscera and unknown injuries. Always you suspect that there are associated abdominal visceral injuries. Kidney injury cannot be simply an isolated injury because it is situated deep in the retroperitoneum. There can be associated visceral injuries, and you'll have to keep them in mind. Types of closed renal trauma. Closed by means there is no tear of the Gerota's fascia. One is a subcapsular hematoma. There is a minor injury to the cortex and there is bleeding. This is called subcapsular hematoma. This is a laceration extending into cortex and sometimes into medulla, and avulsion of one pole and avulsion of the vessels. These are all the gross injuries, which classification of which we will see now. Grade 1 renal injuries, which are most common, there is renal contusion or bruising of the renal parenchyma. Microscopic hematuria is common. You think when the kidney injury is there, there should be hematuria. Though hematuria is very common presentation, sometimes hematuria may not be there if the blood doesn't come into the pelvic system and the ureter, or the vessels are torn. So very rarely, though hematuria may be absent, but hematuria, either microscopic or macroscopic, is the sign of kidney injury. And you also have to remember that in a motor vehicle injury, there can be a urethral injury or a bladder injury also, along with kidney injury. So it takes off your attention. The lower tract injuries, you are likely to miss the kidney injury. So grade 1 is a renal contusion or subcapsular hematoma and doesn't require, it is one of the grade 1 injury. Grade 2 injuries are the parenchymal laceration goes into the renal cortex, limited to the cortex. Perirenal hematoma usually happens and that is small. So grade 1 is only contusion, Grade 2 is subcapsular hematoma due to parenchymal laceration to the cortex. Grade 3, parenchymal laceration extending to cortex and into the renal medulla. There's further extension of the injury into the medulla. Bleeding can be significant, medullary bleeding can be significant, and a large retroperitoneal hematoma can result. Grade 4 injuries to kidney, renal parenchymal laceration, either single or multiple, extends into the renal collecting system. And also, main renal artery thrombosis also can occur due to blunt abdominal trauma. Renal vein or artery vascular injuries are common in this grade 4. Grade 5 renal injuries are multiple grade 4 parenchymal lacerations, renal pedicle avulsion or both, arterial injury from penetrating trauma, main renal artery or vein thrombosis. Ultimately, shattered kidney in a blast injury, blast injuries which are common, they are common in earthquakes and other places, blast injuries. Kidney shattered into multiple parts, it cannot function, it is shattered into so many parts. So that is shattered kidney. So these are all, in a sense, grading of renal injuries, which are very important when you think of managing. So this is a repetition of what is there. When the emphasizing point is, if there is a hematuria with significant, trivial injury, think of pre-existing conditions. So what are the clinical features of renal injury? This is, renal injury is a part of polytrauma. Kidney injury is along with other injuries, it has to be kept in mind. So first thing, whenever an injured patient comes, you have to take care of ABC, is it not? So you have to take care of airway, then blood and clinical feature, ABC. ABC you have to take care of that. See the airway, whether the airway is not properly or not. How are the vitals, how are the blood pressure and pulse rate. Then how is the breathing, rate of the breathing. And all these things have to be taken care of. First, documentation of vitals is very important because deterioration can only be seen when you have a baseline things. So all these things should be entered clearly, and graphic demonstration of any lump or anything should be measured, and you have to see the x-rays and note down any fractures or other things, and then think of treating the renal patient. And after investigations, general investigations and specific investigations. Local pain and tenderness can be there when there is a blunt abdominal injury, simple injury like contact sports and boxing injuries. Hematuria is a cardinal sign of renal damage, but as I said, sometimes very rarely it may be absent. And there can be a severe delayed hematuria, sudden and profuse between third day and third week due to clot discharging. How does hemorrhage get controlled? First, contraction of the vasculature to a clot formation. It happens. When there is a clot dischargement, there will be bleeding. This is called secondary hemorrhage. And kidney injury patients have some abdominal symptoms as well because just above it are the peritoneum, and it also supplied by splanchnic vessels. A retroperitoneal hematoma leads to meteorism. This is called abdominal distension. So once you see this, you have to investigate. This is an X-ray of intravenous urogram of the left kidney. There is left kidney seen here, and urine is extravasating. So this is extravasation of the dye injected, showing kidney injury. This is a CT scan of the abdomen showing injury on the right kidney. There is extravasation of urine. This is how it looks like on investigations. So how do you manage? As I said, obtain intravenous access. Patient may require blood, rapid fluid replacement if in shock. So you have to have an access to intravenous access. Arrange for blood for transfusion if there is volemic or shock. Always better to release it. As I said, there could be torrential bleeding once the clot discharges. And macroscopic hematuria should be assessed frequently. This is called 3-glass test. You ask the patient to collect the first specimen in one glass, next specimen in another glass, and third specimen in another glass. Like this, each time he passes urine, you can assess whether the hematuria is increasing, decreasing, or remaining the same. So this is very important in assessment of hematuria, severity of hematuria. And patient should be given rest if treated conservatively, strict bed rest at least for 1 week, if not move out. For pain, you can give non-narcotic analgesics, hourly monitoring of vitals, and antibiotics to prevent secondary infection in hematoma. Check each urine sample for hematuria. If it is decreasing, it's okay, we are happy. If it is increasing, we must be seeing with some distinct what to do. Critically, we have to see it critically. And the investigations include general investigations for the patient to be, if it is needs to be operated, whether it's fit, is a diabetic, or has renal failure, something like that, baseline investigations to establish the general status of the patient and also fitness for surgery. Emergency intravenous urogram or contrast enhanced CT are the investigations which are to be done in case of emergency. Out of these things, contrast enhanced CT is the preferred mode of investigation because that also assesses the other organs in the abdomen. So IVP gives only kidney status but not other organs, whereas this contrast enhanced CT scan gives information about other organs as well. In a right-sided kidney, there can be liver damage. In a left-sided kidney, there can be splenic damage, and both of these things should be ruled out by contrast-enhanced CT scan. Then there is a kidney injury. You have established that there is hematuria and confirmed by investigations. What should you do? Should you explore? Most of the kidney injuries, closed injuries, are managed conservatively. Blunt abdominal injury with kidney injury, like closed injury, are all treated conservatively only. You follow the vitals, you give blood or fluids as depending on necessary if there is hypovolemia, restrict him, give him bed rest, and follow the severity of the hematuria, decrease of the hematuria by 3 glass tests, and pulse rate, blood pressure check. If they are stable, you don't need to operate on these people. They are managed conservatively in isolated closed injury of the kidney. The indications for exploration are only significant progressive blood loss leading to a pulsating mass in the loin, and patient is not responding to your hypovolemic management, tachycardia, and associated injuries are also there. It need to be explored. Then there is indication for surgical exploration. While exploring surgery, don't think that you have to remove the kidney. Don't go with the thing that you have to remove the kidney for treatment of renal trauma. No. The aim is to stop bleeding while conserving renal tissue. We always should think of conserving nephrons, leave alone renal tissue. So the aim is to stop bleeding if it is possible, and then polar excision, if the kidney can be survived on only one pole is damaged. So if you have this vascular injury suspicion, you have to do an angiogram, wherein you can see the bleeding vessel, multiple or something like that, at least what is the vascularity of the rest of the kidneys, things like that. And there is one vessel bleeding. The conservative management of the renal injuries, that embolization of the bleeding vessel is an important point to manage, to be able to manage even a progressive bleeding conservatively. Then, suppose we have decided on surgical management. What should you do? The approach is transperitoneal because usually we explore the kidney in a retroperitoneal fashion for stones and other diseases. Whereas for trauma, it has to be transperitoneal because you suspect other damages to other organs, abdominal organs. Release of tamponading effect releases massive hemorrhage. As I said, the geratas fascia has a tamponade effect over the hematoma, pelvic hematoma. So unnecessarily you should not cut or rather release pelvic hematoma. There could be massive injury. If the kidney is ruptured or shattered or revulsed from its critical vascular injury, it may need nephrectomy. But otherwise, you have to conserve the kidney, remove it, suture if there is a tear, and if there is cortical injury leading on to the pelvical system, you have to do a nephrostomy and come out. And laceration of one pole, as I said, partial nephrectomy. And in a solitary kidney, you cannot do a nephrectomy because the patient will be left with no kidneys. So always conservative management, even in exploration. But as I said, 90% of the kidney injuries are managed conservatively. There's no indication for surgery in these patients. So, but there can be some complications of renal injury also. Initial hematuria followed by, as I said, due to class dischargement, heavy hematuria can be given, and there can be clot obstruction of the bladder outflow. We had one doctor, an ENT professor, who had injury to kidney, and there was brisk bleeding. We had to do a number of times bladder washouts through cystoscopy to remove the clots coming from the upper tract. So this may require even sometimes a suprapubic cystostomy if there is torrential bleeding. And there is a perinephric hematoma occurring afterwards. And if there is communication to the calyces, there can be urine outside and it can form a urinoma. An injury to the vasculature may result in formation of an AV fistula. Sometimes there is urinary extravasation outside and you treat them conservatively. It can cause a thing called pararenal pseudohydronephrosis. There is complete cortical tear and there is urinary leak. Ultimately, anything heals by fibrosis, this may cause ureteric obstruction by scarring at a later time. And certain delayed effects like hypertension can occur after renal injury. This is due to renal fibrosis. It can be seen only after 3 months of injury, often refractory to medical treatment. But it all doesn't require nephrectomy all the time. As I said, it is due to hyperrenemic hypertension due to page effect of the kidney, which can come down later on. Otherwise, it has to be managed medically. Very rarely, in a small contracted kidney, if the vasculature of the kidney is affected and kidney shrinks, lead to a very small kidney, increasing hypertension, then you will require nephrectomy. Otherwise, it can be managed medically. So, aneurysm of renal artery is another complication of kidney injury. There is pain in the loin, a non-tender swelling, congestion of the parenchyma, and intermittent hematuria results due to the aneurysm. And you do an angiogram, it is diagnostic. And rupture of the aneurysm, because it's important because rupture of aneurysm can be fatal, requiring urgent excision or nephrectomy. So this is regarding renal injuries. You have to remember that kidneys are very well placed in the erythropoietin, protected by the abdominal musculature and the 3 coverings of the kidney: capsule, perirenal fat, xerotas fat, and pararenal fat also is there surrounding the xerotas fascia. So these are all the facial coverings of the kidney which give protection to the kidney. The vasculature is directly related to the aorta and inferior vena cava. So be careful and think of possible renal vascular injuries also. But usually limited to the subcapsular hematoma or minimal extravasation of urine due to cortical tear. So all these things can be managed conservatively by following the patient in the post-injury phase by periodic assessment of hematuria by the T-glass test, monitoring of vitals, and clinical examination, wherein the vitals are stable, urine hematuria is coming down, and patient is responding favorably. All the cases can be managed. More than 90% can be managed conservatively. Very rarely surgery is indicated, wherein your aim is to conserve as much renal tissue as possible and treat the injuries and come out. If it is a shattered kidney, vascular injury, and very much damage, that may result in a nephrectomy. But while exploring, you have to take care not to unnecessarily open up a retroperitoneal hematoma which is contained, because it can lead to loss of tamponade effect and torrential hematuria. Of course, prophylactic antibiotics are given to prevent infection and things. So this is about renal injuries. And associated with that, there is a ureter. Ureteric injuries are also part of upper tract injuries. So we'll come to that now. Once again, you have to recapitulate your ureteric anatomy when you are trying to treat the ureteric injuries. Ureter starts at the L2 level at the pelviureteric junction. And they lie on the psoas muscles, pass medially to this, pass along the transverse process, tips of the transverse process, sacroiliac joints, and then swing laterally towards the pelvis near the ischial spines. Then they turn medially to penetrate the base of the bladder and enter the bladder, urinary bladder. You have to remember here the relation of uterine arteries to the ureter, because most commonly the injuries of the ureter are due to difficult gynecological surgeries lowered on where the ureter is related to uterine arteries. By securing hemostasis, ureters may be injured inadvertently by this. The uterine arteries are closely related to the juxtacervical portion. The ureter cross anterior to the uterine vessels are anterior to the ureter. The vasa differentia also are related to the ureter, but they are behind the ureter. No, there's no problem about that. So you have to remember the relation of uterine arteries to ureter, because the commonest injury is due to difficult gynecological surgery and pelvic surgery. So this is the anatomy of the thing. Uretero-pelvic junction is the narrowest part of the ureter. Then it comes down and crosses the iliac artery, and then takes this curve laterally along the pelvis, comes down the juxta position of the vas deferens and broad ligament here, and then enters the bladder here, and this is the ureteric orifice. So ureter can be damaged anywhere like this. First, uretero-pelvic injuries can be mainly in the children, where there is hyperextension injury of the spine and there is a pelvic junction disjunction. Later on, along with this, it can be injured due to penetrating trauma or blunt trauma. Here, iatrogenic injuries due to difficult pelvic surgeries. And here, ureteric meatus and other things, urologist may be the cause. Instead of saving this inadvertently by instrumentation of others, urologists may cause ureteric injuries. These are seen mainly, as I said, mainly in difficult pelvic surgical procedures, stab or gunshot wounds, rapid deceleration accidents avulse the ureter. As I said, a deceleration injury avulses the ureter at the pelvic junction. Endoscopic basket manipulations of ureteric calculi, as I said, urologist causing ureteric damage. It is quite a contradicting thing. Urologists are supposed to treat all these things, and they themselves may be the reason for these things, because of the over-jealous management, that everything should be managed only endoscopically or otherwise, not choosing the proper way, the endoscopic, laparoscopic or robotic way of treating these things. If you see, as in endoscopic surgeries, ureters are dilated, some sheets are placed inside the ureter, and stones are manipulated by energy sources. So all these things can cause ureteric injuries. A devascularization injury is a very important thing in surgery, wherein you dissect the pelvic lymph nodes, or after radiotherapy to the pelvis or pelvic cancer, devascularization of the ureter can occur, because the ureteric supply comes from the medial side of the ureter along its way, and mobilization should occur different way other than the vascular supply. If you damage the vascular supply, there is devascularization injury. Apart from this blunt abdominal injury and penetrating trauma, devascularization injury is also very important. As I said, blunt abdominal trauma, penetrating trauma or gunshot wounds, iatrogenic injuries by gynecologists and urologists and general surgeons, deceleration injury, and another important thing is this injury can be unilateral or bilateral. If it is unilateral, it may go unrecognized, but in bilateral, patient presents with anuria, which is a very devastating condition of a post-operative condition. We'll go through that. So rupture of ureter is uncommon, but only seen in avulsion of the PUJ in children, because the lack of sheaths, perirenal sheaths of fascia, gyrata fascia are not well developed, and pararenal fat is also not there. Mostly, this avulsion of PUJ occurs in children due to deceleration injury or hyperextension injury of the spine. When there is swelling in the loin or iliac fossa with decreased urine output, you have to suspect rupture of ureter in a child. Of course, excretionary urogram, excretion of the contrast from the ureter on the injured side, or that side your kidney cannot be seen. That is called non-visualized kidney can be there in injury to the ureter in children. So the other thing I have shown you, the extravasation from the ureter. So you see here, ureteric injury, this is kidney seen normally, ureter, and there is a lot of urine extravasation here. That means the ureteric injury here. This is how it looks like an intravenous urogram, ureteric injury. And injury to one or both ureters during pelvic surgery is an important thing, iatrogenic cause. This is far more common than ureteric injuries in blunt abdominal injury or penetrating trauma. Because this is very much frequently done, far more common because of the surgeries done. Now, even with laparoscopic and all these surgeries, still uterus can be injured. People used to avoid this by putting a stent in the ureter as a preoperatively to recognize ureter in the intraoperative period when it is difficult. It occurs more often due to vaginal or abdominal hysterectomy. Difficult hysterectomies which bleed. Bleeding is the cause. When there is bleeding from the uterine arteries or that pedicle, there is haste in securing hemostasis. You apply a clamp for hemostasis that involves the ureter. And if it is done on one side, unilateral injury. If it is done on either side, then the bilateral ureteric injury. Ureter can be damaged in so many ways. It can be divided, ligated, crushed, or excised inadvertently. This happens even in some abdominal surgeries like AP resection of the AP resection thing, rectum for rectal cancer, AP resection. You can injure the ureters, one by cutting or devascularizing it, as I said. So prevention is preemptive ureteric catheterization because it will be turned into a rigid one, and you can identify it by palpation intraoperative. So how to manage? The management is one, when you recognize it at the time of the injury itself, or when you recognize it at a later time. So both are like this. If you recognize at the time of injury itself, an operation, you'll have to treat immediately. Restoration of the uretero-ureteric continuity is obligatory. By deligation, if it is ligated, deligation and put a stent. If you deligate, simply only deligate, you have to put a stent so that it heals. Then if it is cut, then end-to-end anastomosis, end-to-end spatulated anastomosis if it is cut, and stenting when in doubt. When you deligate or when you are not sure of the vascularity, you stent it. Open stenting or cystoscopic stenting. This one was done previously. If the patient condition is poor, deliberate ligation of the proximal end of the ureter and temporary percutaneous nephrostomy is in the books, but not followed nowadays, because immediately you can do a percutaneous nephrostomy, and kidney ligation leads to, people used to think it undergoes silent atrophy, but kidneys do not die silently. They make a lot of noise and cause this thing. So this is only a last resort in the textbooks, but not in the practicals. And suppose injury is not recognized at the time of operation, what to do? So the unilateral injury usually escapes. What we think in immediate post-op period is, if there is decreased urine output, we think that it is a thing in the immediate post-op period due to lack of fluids, and treat accordingly. You have to suspect that you might have injured the ureter at the time of operation, and swallow your pride, investigate and treat it. Always you should think of the patient, not your name and ego. If ligation of ureter, silent atrophy, sometimes it may not be recognized. Sometime later, if it is investigated, you find a hydronephrotic kidney which is not functional. So silent atrophy is one of the things. But usually, as I said, kidneys do not die silently. With other kidneys functioning, this kidney takes over the function of the opposite kidney, and there will not be any signs of renal failure or anything like that. If you assess by renogram, then there is this thing. If you still there is function in the kidney, you can do a percutaneous nephrostomy and definitive surgery later. If on investigation for another cause, if you find immediate post-op period or within 6 weeks or so, then you can do a renogram, assess the function, and if there is function, you have to try to conserve the function by doing a percutaneous nephrostomy and then do definitive surgery depending on the situation. Clinically, these people present with loin pain and fever. With pyonephrosis, obstruction causing infection will be there. In the immediate post-op period also, they present like that. Or later also, they can present the loin mass and fever. And when you do an intravenous urogram, you find that there is no function. and requires an urgent intervention like percutaneous nephrostomy to save the function, which has become easier now. When we were in training, we used to do by open operation. Now at least percutaneous nephrostomy is easily done now on the bedside without moving the patient to the theater. Sometimes it presents as a urinary fistula through the abdominal or vaginal wound. How do you know it is urine or something else? Because usually you think that it is some other discharge other than urine. The abdominal wound site also sometimes urine comes. Then you have to test for the urine. Urine, if you test for creatinine, levels are very high than serum value. And if you ask the patient, inject some indigo carmine, the discharge will be colored red. Then you are sure that the discharge is urine and not anything else. And then you do an intravenous urogram. You find extravasation of the contrast with or without obstruction to one or both ureters. There is some urinary leak. There is that urine leak suggests that the kidney is functioning. Otherwise, it will not be secreting urine. And you do a temporostomy, percutaneous nephrostomy, and do the definitive repair later or delayed. Early repair if the patient is fit and it's only something like deligation or something like that. Then a bilateral injury, as I said, is a devastating thing. Urgent relief is mandatory as it leads to anuria. Suspect if the urine output is reduced or absent in the immediate postoperative period. This happened, I had to see one or two patients like that. When the surgeon immediately next day thought since there is no urine output, ureters could have been injured. We went and explored. We found that they are ligated on both sides. Just deligated and put stents, both the kidneys recovered. And anuria is life-threatening things. Can be there for 3 or 4 days like that, nothing may happen. But gradually serum creatinine goes up, patient lands in acute renal failure and sometimes patient may end in death also. So what to do immediately if there is bilateral ureteric injury? You have to conserve the kidney function by doing a percutaneous nephrostomy. Though it is mentioned as stenting, it may be difficult, very difficult to stent because of the obstruction. So if you cannot stent, then immediately you do a percutaneous nephrostomy to salvage the kidney. Suppose ureter is damaged, there is loss of length of the ureter which is managed, or the upper ureter is damaged, lower ureter is damaged. So depending on the site of the injury and the nature of the injury, you plan for repair of a damaged ureter. If there is no loss of length, if the ureter you have ligated, there is a suspicious that ureter is going to survive or not, then you excise and make a spatulated end-to-end anastomosis without tension. That is called ureterostomy. Any stent anastomosis, you prophylactically stent so that it heals better and urine is diverted. Then there is little loss of length, small little loss which can be obtained by mobilizing the kidney. If there is upper ureter, if you mobilize the kidney and bring it down, you may be able to repair with a little amount of loss of strength. But loss of severe loss of thing, you may have lower ureter, you may have to do a Soa-Stitch procedure or a Boaris operation. That means we'll come to that later. And if there is marked loss of the length and it cannot be brought down by Boaris flap, you do a transureterostomy. You take the ureter to the opposite normal kidney and anastomose to the ureter there. That's called transureterostomy. This is one procedure. The other one is using the bowel, isolated bowel, to create the length of the ureter to come down. This is all done very rarely. And then the other thing is autotransplantation. You bring down the entire kidney to the iliac fossa if there is severe loss of ureter, and then autotransplant. Nothing can be done. Kidney is damaged, not functioning. Then you have to do a nephrectomy. This is a Boaris operation, the Boaris operation, wherein a strip of the bladder is fashioned into a tube to bridge the gap between the cut ureter and the bladder. Suppose ureter is lost, is higher up. And if you bring this ureter to bladder, you see there will be tension. Then you take this is a bladder wall. This is the flap of the bladder which is taken, and this is made into a tube and it is put here. So you are gaining this much of length. So this much of loss of ureter can be managed by taking a bladder flap and anastomosis to the ureter. Urine is very happy in its bladder, in the bladder. Suppose you put intestine or something in place of urinary tract, urothelium, there will definitely be some changes, some occurring, biochemical changes occurring, and some complications occurring. So this is the easiest way of managing the loss of length of ureter lower down, the lower ureter. So you can take a bladder wall, make it into tube and anastomosis. So that is the thing. So recapitulating, the ureter is also very well concealed in the abdomen, in the retroperitoneum, very much in relation to the transverse process, tips of the transverse process of the lumbar vertebrae, comes down, takes a lateral curve along the spine to discal spine, turns medially, and then joins the bladder, crossed anteriorly by uterine vessels and posteriorly by vas in the main. So ureteric injuries are common in automobile, in penetrating trauma, or sometimes the blunt abdominal injury in children, where there is pelvic junction avulsion. But mostly ureteric injuries are iatrogenic, either pelvic surgeries, gynecological surgeries, or general surgical procedures, like abdominoperineal resection or intestinal resections and other procedures, either done laparoscopically or by open operation also. So you have to know the anatomy of the ureter and anatomy of the ureter in relation to the vascular supply before you intervene. So ureters are also completely anatomically seen by one by IVP or two by retrograde pyelogram, where you can see the entire anatomy of the kidney, or you can do a contrast enhanced CT if there is any localizing of the abnormalities in the ureter. So iatrogenic injury is common. Don't just try to support the deficient function of the kidney, decrease urine output due to other reasons, that patient was in shock or fluids are not given properly, something like that. You have to have a high index of suspicion for ureteric injury when you have done a difficult pelvic surgery or a difficult hysterectomy and there is decreased urine output in the postoperative period. Luckily, ureter is damaged only on one side. It may not manifest immediately unless there is a leak by means of a fistula. Injured and there is a leak on one side also, it leads to urinary fistula, discharge of urine through the abdominal wound or through the vagina. Then you'll have to prove that it is urine by analysis, wherein the creatinine value of that discharge is very high compared to the serum creatinine value. The other one is you inject intravenously indigo carmine, then this discharge will be colored red. So there is no mistake that it is urine. Urine anywhere outside the urinary tract is an irritant and causes a lot of damage. So you have to treat this. So how to treat this? If it is a unilateral injury, patient is stable. First you try to do a stenting. If you are able to put a stent from below cystoscopically, then that solves the problem. If you are not able to put a stent, then you have to do a percutaneous nephrostomy. There is hydronephrosis to salvage the kidney to plan for definitive treatment. The patient is stable, very vitals are normal. You can do it in immediate postoperative period itself. Don't need to wait. Ideally, it is done before 7 days of surgery, or laterally it can be deferred because there is a lot of edema and damage at the site of operation if it exceeds that. Immediately you can intervene next day itself, no problem. The patient is stable if you suspect ureteric injury. If there is injury with loss of ureter, then you have to various modalities of managing the length of the ureter. One such thing is mobilizing the kidney, bringing it down, and or doing a psoas operation or a transuterine ureterostomy for the loss of length of ureter. But of these procedures are available, you choose what is the best. There is no loss of injury, loss of length of the ureter. It is very easy to spatulate the ureter and make a ureteroureteric anastomosis. This is called ureteroureterostomy, And always when you suture a ureter, you put a stent because that facilitates healing and drainage of urine in the immediate post-op period. So you have to avoid ureter while doing surgery by one, your sound anatomical knowledge. You have to remember that ureter is there. Ureter is identified in the abdomen by virtue of its peristalsis. There is a if you tap the ureter, there is peristalsis, and it's a tubular structure close to the transverse process, and vascularity comes on the medial side. So identification of ureter is important while doing pelvic surgeries. If it is difficult, we are expecting difficulty, put a preoperative stent so that you can identify the ureter at the top operating table itself. Endoscopic damage to the ureter is very much there by basketing of the stones, or nowadays you are doing retrograde intrarenal surgery by passing flexible or rigid ureteroscopes and doing stone blasting by using various modalities, laser and other areas. So all these things can damage ureter. No procedure is devoid of complications. So you'll have to suspect all these things. And ureters have been avulsed previously. Used to be basketing, where you pass a basket to take the stone out. People used to bring the ureter out by manipulation. So you'll have to be very, very thorough about your anatomy and very gentle about the procedures. Otherwise, you end up damaging the ureter very frequently. In the training, and you should not damage. Should keep in mind the patient is always supreme, and you have to have the benefit of the patient in mind. If you are in difficulties, call for help. Swallow your pride, call for help, then do the procedure, but not just do it and cause damage. Students, this is about injury to kidneys and ureter. And if you have any questions, you can ask me. Right? Next class will be on bladder and ureteral trauma. We are continuing. We have finished the kidney and ureteric injuries. And as I said in the beginning itself, we will be teaching you as what an undergraduate needs to know. As a basic doctor, your responsibility is to identify the emergency and assess the patient and treat or refer the patient to a higher center. Okay. Any questions? Any questions? I don't know if you don't have any questions, either you have not followed it all. I'm sorry that I did not send it earlier. Today morning only I could send it. The PDF version of these slides. Okay, if there are no questions, we'll stop for today. Thank you.